It's my distinct honor to get David Menn. I'm his silent admirer. And the co-PI of ischemia trial that you have seen all, and the Renberg professor, the chief of the Stanford Prevention and Cardiovascular Clinic. So David Maron on chronic coronary disease guidelines, what is new besides the name? Very grave topic. David.
Thank you.
Thank you.
Thanks so much. Good morning. Thank you so much for the invitation to speak at this conference with such distinguished faculty. I need to figure out how to find my...
I like American cardiology so much that I didn't want to bring that down.
I got it. I figured it out. There we go. And I'm not even a New Yorker. Okay. So this is what Dr. Narula asked me to speak about, what's new in the guidelines for chronic coronary disease. My disclosures are that I'm a preventive cardiologist, not an interventionalist or other subspecialist, and I was not on the writing committee for these guidelines. And I was not allowed to be on the guideline writing committee because of my participation in the COURAGE and ischemia trials, which was incredibly frustrating for me, not to be able to have a voice in writing the guidelines. So the job that I have for the next 30 minutes was made easy because the ACC-AHA has a slide set on what are the guidelines. And so I didn't have to create a lot of slides and just think about what am I going to say. But what I want to do is talk about what, particularly what I think is important that is new about these guidelines. And I want to start by asking you, what's missing? What's missing from this title slide from the slide set? What's that? Okay, I'll tell you. This guideline was not endorsed by the cardiovascular surgery committees or societies. Unlike in 2012, the American Association for Thoracic Surgery and the Society of Thoracic Surgeons endorsed the guidelines and always had since there is since the creation of guidelines endorsed by multiple societies. And I'll come back to that a little bit later. So the first thing I thought that is new that I should mention is the name, chronic coronary disease. You know, we talk about stable coronary artery disease, and then a little over a decade ago, it was SIHD, stable ischemic heart disease, and now for some reason there's a new name, chronic coronary disease. And just because I'm not sure what the reason is, but we have a different name than the Europeans who changed the name of stable coronary disease syndromes to chronic coronary disease, or I'm sorry, chronic coronary syndromes, CCS. Kind of cute because we know we're also familiar now with the terminology ACS, and CCS is nice. We had to be different for some reason. Well, what does it mean? What is chronic coronary disease? If you look through the guidelines, it's actually, what's stable coronary disease has never really been defined. And now we have a definition, and it's it's a gamish, it's a mixed up, it's a lot of things. So it's patients discharged after ACS once the acute problem is resolved, or post-revascularization, that's chronic coronary disease. Patients with coronary disease and reduced EF, or ischemic cardiomyopathy. Patients with stable angina or angina equivalent that's medically managed with or without any stress test that supports the presence of ischemia. Patients with angina due to vasospasm or microvascular dysfunction. And if a doctor says the patient has chronic coronary disease. The patient has chronic coronary disease. So that's the way it is. And this is, I'm happy to say, very consistent with what how the Europeans define chronic coronary syndromes. People in the United States with CCD number about 20 million. Interestingly, and I guess this is sort of a pet peeve, but I don't blame the guideline writing committee for excluding asymptomatic severe coronary calcium as chronic coronary disease. It's not part of the definition, but we know that severe coronary calcification means that there's a lot of plaque that's calcified, which defines coronary disease. So they do say that people with extensive calcification deserve aggressive GDMT, but it's not part of the definition of chronic coronary disease. So is somebody with a high calcium score primary prevention? Is secondary prevention? What do you call it? And maybe we'll talk about it. I think you're all familiar with the method of classifying the recommendations and the quality of evidence, but just a quick reminder, class 1 is something that should be recommended, and class 2A is something that is reasonable to recommend, and 2B is maybe reasonable, and a class 3 recommendation is either there's no benefit or there's actually harm. So don't do it. And I did that quick summary because I'm going to go through the recommendations. Most of these are new that I'm going to share with you now. So for the first time in the guidelines, it is recommended weekly that patients with chronic coronary disease, these patients, use of a validated patient-reported outcomes measure should be considered, or it may be reasonable to assess symptoms. And this is important because and I'll get to this later, the guidelines for revascularization have changed, and the patient's symptoms are a really important part of this shared decision-making process. Should a patient be revascularized? Well, historically, we use the Canadian Cardiovascular Society, what we think the patient's angina severity is, but this is now introducing for the first time the idea that the patient should report what their symptoms are, and hopefully this will become an important part of the decision about whether or not to revascularize. Now, this is a very busy slide because things are complicated. As Kathy Biga just showed you some slides about all the factors that should be considered in the care of patients. This is divided into, on the right-hand side, the clinical care team. The physician or APP is one of these arrows, the clinical expertise, but you really should have expertise from a dietitian, somebody with expertise in exercise, and the social determinants of health need to be considered, and the patient's literacy as somebody who is skilled in educating a patient. And on the left-hand side, the patient factors. So to do shared decision-making, which is in the center here, involves a lot of variables that, frankly, cardiologists aren't trained to do or be master of. And so it really does require a team, and it's a class 1 recommendation that a multidisciplinary team should be involved in the care of patients with CCD. And this is just a figure from the guidelines showing the different levels of expertise. Now, I don't know what your practices are like. I don't know if you have a built-in go-to person for dietary counseling, or maybe how to start an exercise program, or for weight loss, or for managing stress, or maybe genetic counseling if it's a patient with familial hypercholesterolemia. But it really takes a team to provide optimal care. And a Class 2B recommendation may be reasonable for patients with chronic coronary disease and angina on guideline-directed medical therapy, to have available a decision aid to make a decision. We're really talking about revascularization. Now, the college has developed this new interactive tool online to help with the choices of medications. And so this is a step in what I think is the right direction to optimize medical therapy for patients. And as a result of what we learned in ischemia, under the leadership of John Spertus, we've developed what I think the new guideline, even though it's a 2B recommendation, is recommending. And this is a tool for patients and their providers to enter the patient characteristics and calculate what the likelihood is that they'll have angina if they have revascularization a year from now, or what's the chances that they'll be alive if they have revascularization versus medical therapy. And hopefully this will be an important take-home from the ischemia trial that you'll be able to use in your practice. The website is live at myhealthoutcomes.org, and you might enjoy fooling around with it and see what's on there. It's a Class 1 recommendation. This is something new to assess the social determinants of the patient's health. And this is so involved. I know the lingo. How do you determine what the determinants of health are for a patient? And this is a complicated slide with small font that you're not going to read on this slide, but it's in the guidelines about, and for example, I'll read here one that has only a couple of check marks for education and health literacy. Assess health literacy. Do we do that in our practices, assess health literacy? I mean, we talk to patients and kind of, okay, you understand maybe what their level of education is and how to frame your explanation for what you're recommending, or even just to understand what their status is health-wise. Provide patient education materials at the appropriate education level. We have a lot of work to do. I hope the president-elect of the ACC can come up with some solutions for how to address the social determinants of health, because we ain't trained to do it, and it takes a team. I was happy to see that the new guidelines cast aspersion on the many supplements that our patients take. I think fish oil is probably the most popular, not to be confused with what you'll hear later today from Dr. Bod about a purified form of fish oil, but the over-the-counter fish oil supplements, no benefit. And it says no benefit, it doesn't say harm. And all the vitamins, I mean, the best thing that I've seen is maybe a multiple vitamin might prevent certain kinds of cancer. It's hard to really justify a lot of what our patients are taking. Okay, lipid management. You know, it was about a decade ago when the guidelines for lipid management really changed, and it was, okay, they're high-intensity statin therapy. This is what high-intensity statin therapy is, and the goal is to reduce the LDL by 50%. And it got away from an LDL goal. The lipid guidelines, and they've been incorporated into the new chronic coronary disease guidelines, really do have an LDL goal of less than 50. Excuse me, that was a slip because that's what I think, but it's less than 70 for patients with chronic coronary disease. And the way to get there is after high-intensity statin, add ezetimibe, and if you're not there at less than 70, add a PCSK9 inhibitor, and now we can say bempedoic acid in terms of evidence for clinical outcomes. And hopefully we'll see a similar clinical outcome benefit from inclisiran, but we don't have that evidence yet. How do you define very high risk? Because the less than 70 was for the very high risk. My own personal editorial remark would be everybody with atherosclerosis should have aggressive lipid lowering, but the guidelines say for very high risk, less than 70, and how do you define very high risk? Basically, it's somebody who's had an event, typically an MI, and a couple of other risk factors. And it's the list of risk factors that we see in virtually all the patients that we take care of. SGLT2 inhibitors and GLP-1 receptor agonists are now in the guidelines because of the great evidence in recent years. This is the first set of guidelines since all of the clinical trial data supporting the use of these drugs in patients with diabetes and coronary disease. And also for patients with obesity, there's a 2A recommendation to use GLP-1 receptor agonists. And I know that you're all aware of the tremendous frenzy of using these drugs for obesity and maybe being a few pounds overweight in our society today. Antiplatelet therapy, and I've just highlighted one aspect of the new guidelines for patients with oral anticoagulants. What do we do? Largely because of the Augustus trial. The recommendation is triple therapy just for a month, and meaning DOAC, clopidogrel, aspirin, and then drop the aspirin and continue DOAC. This is following PCI. Continue the clopidogrel for a total of 6 months, and then drop the clopidogrel with DOAC alone. Now, for patients that don't have an indication for a DOAC, for anticoagulation, and this is because of the COMPASS trial, there is now a 2A recommendation for patients with chronic coronary disease who are at high risk of recurrent events, but not at high risk for bleeding. A 2A recommendation for low-dose rivaroxaban plus low-dose aspirin. Probably the headline for these guidelines is the beta blockers. This has been standard part of our guideline-directed medical therapy for decades, and the guidelines have changed significantly. Now, for patients with a previous MI who have a normal EF, they don't have arrhythmias or uncontrolled hypertension, after 1 year, the indication for beta blocker is questionable. And so, on patients with so many drugs, as all of our patients are, think about stopping the beta blocker because there's just not evidence that they're useful after a year after MI. Now, in patients who have not had an MI and they have a normal EF, beta blockers have not been shown to prevent major adverse cardiovascular events. So there's a reduction in the enthusiasm for the use of beta blockers in our guidelines, and I think it's a long time coming. Colchicine has made its way into the guidelines as a Class 2B recommendation, so it may be considered, and there's no comment about which patients, for example, with regard to their level of systemic inflammation. There's no recommendation that you should consider this in people with an HSCRP of 2 or greater, as some of us are incorporating into our practice. But it may be considered based largely on the Lodoco trial, and to some extent Colcott, which was a trial of patients with acute coronary syndrome. And now maybe to the most controversial part of the guidelines, and getting back to why do the surgeons withdraw from the guideline writing committee and withdraw their endorsement of these guidelines? So in 2012, the SIHD, the Stable Ischemic Heart Disease, now Chronic Coronary Disease Guidelines, had a Class 1 indication for CABG to improve survival in patients with 3-vessel disease or 2-vessel disease, including proximal LAD. In the 2021 revascularization guidelines, this changed. It was demoted from a Class 1 to a Class 2B, so it dropped 2 categories in terms of level of recommendation in patients with stable coronary disease and a normal EF and 3-vessel disease. So CABG no longer recommended to improve survival for patients with 3-vessel disease and a normal EF. That was 2 years ago, and the surgeons removed themselves from that guideline writing committee and did not endorse that guideline and came out with scathing criticism. And I was a little bit wrapped up in that criticism because they attributed this change due to the ischemia trial. It wasn't, first of all, ischemia trial investigators were not on the guideline writing committee. And second of all, the guideline writing committee did it on the totality of evidence, not just the ischemia trial. But the truth is, since the big CABG trials in the late 70s, early 80s, there hasn't been any evidence that in a randomized controlled fashion that CABG improves survival in patients with 3-vessel disease. So now the new guidelines for chronic coronary disease, I'll start out with an easy one. Class 1 recommendation for left main or multi-vessel disease in the setting of a low EF, less than 35%. CABG is recommended to improve survival. And I think, and I don't have any inside information, but I think that the guideline writing committee did a little political decision not to head on address 3-vessel disease, normal EF. It's not in the guidelines whether or not CABG should be performed to improve survival for people with 3-vessel disease or 2-vessel disease and proximal LAD. I think they dodged, and instead gave a 2A recommendation for people with multi-vessel disease, saying not to improve survival, but to reduce the risk of spontaneous MI and unplanned urgent revascularization or cardiovascular death, not all-cause mortality. So I suspect that they were just sort of trying to appease, but that's just my speculation. Surgeons withdrew anyway, and I just explained what this slide was asking, and the surgeons very recently, in the last couple of weeks, the first two were on the writing committee, as I understand it, wrote their critique now of the chronic coronary disease guideline, just saying that it's misguided and surgery should be recommended to improve survival. So in summary, what's new? There's an emphasis on team-based care and patient-centered care that considers the social determinants of health. And I didn't really mention it at all, but there's also a consideration of cost now in the guidelines, and that's new. There's an emphasis on shared decision-making. SGLT2 inhibitors and GLP-1 receptor agonists are now part of the guidelines for patients with coronary disease and diabetes, and for people with obesity without diabetes. Beta blockers have been ratcheted down in the guidelines unless the patient has ischemic cardiomyopathy or another, angina or another indication for a beta blocker. Shorter duration of DAPT is now recommended in many scenarios, and CABG is no longer a class 1 recommendation to improve survival in patients with 3 vessel disease and a normal EF. Thanks for your attention.